As a geriatric oncologist, I spend much of my time with patients who are 65 and older, and treating these patients can be quite complex for a number of reasons. Not only do I address the cancer, but then I get to look at all of these other complex conditions and really have a good conversation with the family and the patient about what's going to serve their goals the best way. Medications for other medical issues in older cancer patients play a huge role in a number of different ways in cancer treatment. Most people over the age of 65 are on 5 or more medications. If they've got diabetes, if they've got heart disease, there are national guidelines that recommend a certain number of medications for those illnesses. Add to that medications for supportive care for the chemotherapy, and we're increasing that. So we have to deal with, number one, adherence to medications. And in our Senior Adult Oncology Center, we have a pharmacist, a geriatric pharmacist, who reviews all the medications with the patient and the family and the caregiver, and talks about what medications might not be beneficial, how to reduce the burden of medication, and what medications potentially could interact with treatment. She also assesses adherence, and by assessing adherence to medication, we can understand what reliability the patient might have. But in fact, if the patient and the caregiver don't have a good sense of medication adherence, you could wind up in trouble. So we have to be very, very cognizant of that, and that also includes a lot of communication with other providers to make sure that the medications really are necessary. The relationship between anemia and frailty is a complex one. Anemia can be a result of many different diseases and can be associated with having cancer. Anemia can be associated with iron deficiency, blood loss, chronic illness, and treatment. When a patient presents with a cancer and they're already anemic, this can be part of what we call the frailty phenotype, meaning they have less exercise tolerance, less endurance. Especially if they have cardiac issues, it can be much more difficult for them to have endurance. So occasionally we will see anemia for which we can't find a cause, and it may be part of aging and part of the frailty phenotype. Whenever possible, we try to correct anemia, but it can predispose patients to increased mortality and worse outcomes on treatment. If it's directly related to blood loss from, let's say, a colon cancer, and the colon cancer is treated, then that can be corrected. But more often than not, it's multifactorial, and it's related to other illnesses, being older, getting treatment, and maybe even some iron loss or some inability to absorb, which can happen in the older patients. Cognitive function in older adults with cancer is a subject that is being researched more and more. What we currently know is that there is a prevalence of about 3 to 7% of dementia or cognitive impairment in patients who have cancer. We are trying to understand now what makes patients with cognitive impairment worsen with treatment and what we can do to try to lessen that impact. Some of the research has shown that patients who go into treatment with cognitive impairment may have worsening cognitive impairment at the other end of treatment. So it is something that we are seeing, and it's something that we are trying to address so that we can, again, maintain as much function as possible in these patients, try to maintain independence, and offer them a treatment that will maintain their quality of life as much as possible, and if we can cure them, even better. Psychosocial health in the older oncology patient is really important and often overlooked. These patients are just as likely to have issues with depression, anxiety, even pre-existing mental illness, drug use and drug abuse, and we don't always delve into that with our patients. I think performing a geriatric depression screen is very, very helpful, but also going back and periodically asking the patient, How's your mood? How are you feeling? Do you feel like this is working for you? And really trying to identify anxiety and depression so that we can refer them to therapy, so that we can get them on medication if that's appropriate. One thing about elderly patients is that they tend to be a little bit more reserved. They tend to complain less. And we don't always get to pick up on what's going on. They may have anxieties about other things that they're not sharing, like a frail spouse, or worried about their family. And we really need to have a good understanding of what the psychosocial elements are of the patient. But it's just as important to address this in the older patient population as in the younger patient population, because they have an incidence of depression and anxiety as well. And it can really make a difference in your ability to care properly for the patient. Comorbidities in clinical trials are measured in different ways. We discussed briefly that, yes, comorbidities can be on the exclusion list. And we are trying very, very hard in the Cancer and Aging Research Group and in the geriatric oncology world to design trials that are meant for older patients so that those comorbidities will be a part of who the patients are, and we can really understand more about the medications, the side effects, in the context of the patients who get the disease. We use different indices. There's one called the Charlson Comorbidity Index that will help us to understand a little bit about function and what to expect from patients and how they may tolerate treatment. The comorbidity indices help us to stratify patients. The aging population is much more likely to develop cancer than the younger population. My hope is that, one, we can increase clinical research in this patient population. We need to design trials that are just for the elderly. The elderly are a heterogeneous population, and we really need to address that. I think we also need to see the development of aging institutes for healthy aging to be able to treat patients as an individualized way as possible. You know, this is really, geriatric oncology is really personalized medicine. We're really trying to find a way to help patients maintain their quality of life while offering them the best treatment possible.